Thank you very much for the opportunity. So today my topic is asymptomatic and normocalcemic hyperparathyroidism, an update. What is the story of hyperparathyroidism? It's kind of a changing profile, and as we all know, hyperparathyroidism is associated with symptoms like renal involvement, nephrolithiasis, nephrocalcinosis, hypercalciuria, and when we take bones, osteoporosis, fractures, and metastatic calcifications, peptic ulcer disease, so on and so forth. But what happened to this profile over the years? If you see, over the years, the symptomatology, nephrolithiasis and skeletal disease, in 1930s, the percentages of presentation compared to 2009, it has markedly reduced. And same way, if we take asymptomatic presentations, when we compare 1930 to 2009, the percentage of presentation has markedly increased from 0.6% to 80%. And with that, we have been able to describe phenotypes of hyperparathyroidism, and this is US data in 1984 to 1993. You can see the gray color, the prevalence with asymptomatic hyperparathyroidism versus symptomatic in dark color. So majority of patients had been asymptomatic with hyperthyroidism. But as we go on, in 2010 to 2013, there is an emergence of a new entity or a new phenotype, that is normocalcemic hyperparathyroidism, in addition to the majority of asymptomatic hyperparathyroidism and symptomatic hyperparathyroidism. So what is this terminology? We know that primary hyperparathyroidism is basically high calcium levels and high PTH levels, and majority being asymptomatic in literature. Normocalcemic hyperparathyroidism defines normal calcium level with increased PTH levels, and again, both symptomatic and asymptomatic groups can exist. So in my talk, I will mainly concentrate on asymptomatic hyperparathyroidism and normocalcemic hyperparathyroidism. What is asymptomatic primary hyperparathyroidism? By definition, it is primary overactivity of parathyroid glands supported by increased calcium levels as well as increased PTH hormones detected biochemically with no related physical manifestations. So that's how it differs from symptomatic primary hyperparathyroidism. But mind you, we need to make sure that the DDs are excluded, such as drug-induced disease as well as FHH, where both can have mild elevation of PTH and calcium, but the patients being asymptomatic. So if we look at the region, these are Chinese data, and asymptomatic primary hyperparathyroidism, the prevalence had been 5.9% in early 2005, and it has increased to 35%, nearly 35% in 2019. And Indian data, again, nearly being 0% probably due to lack of reporting, but it has increased to 13% by 2019. And progressive rise in the prevalence of asymptomatic primary hyperparathyroidism is seen. When we compare the regional data with the Western countries, you can see a marked difference. Asymptomatic disease, although it is progressively increasingly reported, it is still 5.6% overall compared to the more than 80% asymptomatic disease in Western countries. So in our region, majority of the patients with hyperparathyroidism do present with symptoms or later in their disease course compared to the Western countries where routine screening for osteoporosis and calcium analysis is done as a routine screening. And you can see the prevalence increases, the rate of detection increases, but still, in our part, the asymptomatic hyperparathyroidism remains slightly lower, the prevalence lower than the symptomatic. And age of distribution, again, some Chinese data, again, in mid-50s, 50 to 59 would be the most prevalent age group of presentation in asymptomatic hyperparathyroidism. So what is the biochemical profile of this asymptomatic hyperparathyroidism versus symptomatic hyperparathyroidism? So if towards your right-hand side is, this is the PTH level, right-hand side is classified as symptomatic patients having more values than asymptomatic. So in PTH levels, if you take PTH, the symptomatic hyperparathyroidism group have more PTH levels detected compared to the asymptomatic hyperparathyroidism. Mind you, both have high elevated PTH, but relatively higher is seen in symptomatic group. Same as for calcium levels, symptomatic group showing higher calcium levels compared to the asymptomatic group. And when we take the vitamin D, it's the opposite. We have, like this systematic review has shown that asymptomatic hyperparathyroidism shows relatively higher vitamin D levels compared to the symptomatic group, although both groups have relatively low compared to the normals, but comparing these two groups, asymptomatic group has relatively higher vitamin D levels. And in conclusion, with biochemical profile, asymptomatic primary hyperparathyroidism has calcium levels within 1 milligram per deciliter from the upper limit, slightly elevated PTH level 1.5 to 2 times, phosphate either normal or low normal. It's not very low like in symptomatic hyperparathyroidism. Urine calcium excretion is raised only in 1/3, and vitamin D levels are low, but much higher than the symptomatic group. Okay, we've discussed about the biochemical profile. What is the endocrine damage in asymptomatic primary hyperparathyroidism? We know symptomatic group may present with complications or just symptoms as well, but these people are classified as asymptomatic. Are they really asymptomatic, or are there any damages done? If you just concentrate on this, the table, this is a study which ran through 15 years, you may see that the mean calcium levels had been relatively quite static over the years of these asymptomatic hyperparathyroid patients, so as the PTH level. But when went into details, there had been a disease progression in 38% of asymptomatic patients over the 15 years. And concentrating on the BMDs, on DEXA scan, lumbar spine BMD had been quite relatively stable, whereas femoral neck BMD and markedly the radial, distal 1/3 of the radius BMD had declined over time, especially towards the latter part of this study, the decline had been more marked. Well, they postulate because the distal radius has more cortical bone and hyperparathyroidism affects directly the cortical bone. And same study, they have looked at patients who had undergone parathyroidectomy and what the BMD had been following parathyroidectomy. You may note that over the years, following parathyroidectomy, BMD, the bone mineral density had risen slightly and progressively, indicating that this is due to although asymptomatic, due to the raised parathyroid hormones. What about vertebral fractures? This graph shows the symptomatic versus asymptomatic group compared with controls with regard to vertebral fractures. You may appreciate that both symptomatic and asymptomatic group had significantly higher vertebral fractures compared to controls. Although classified as asymptomatic, this group also has had vertebral fractures. In analyzing the asymptomatic group, then the investigators have shown that those who had DEXA T-score less than 2.5 had relatively a higher fracture number of cases with fractures compared to the group who did not have DEXA score less than 2.5. And this group, although you can see a slight difference on the graph, it was not very significant compared to the controls. So this, you may know that this is the surgical criteria for surgery, the DEXA's criteria. So having surgical criteria met, this group had a significant higher fracture risk in the asymptomatic hyperparathyroid group. Switching on to the renal complications, again, among 102 asymptomatic hyperparathyroid patients, 4.9%, although they are said to be asymptomatic, had an eGFR less than 60, and nephrolithiasis and nephrocalcinosis on ultrasound scan were seen in 18%, and 24-hour urine calcium excretion more than 400 milligrams were seen in nearly 30% of this cohort. And this is ultrasound detected nephrolithiasis and nephrocalcinosis. Importantly, if you compare the same group, this is a different study actually, comparing ultrasound and CT scan, 30% of ultrasound negative cases will become positive if done a CT to detect nephrocalcinosis or nephrolithiasis. So ultrasonically detected negative does not mean that they don't have nephrolithiasis. Therefore, the previous study, maybe this is an underestimation of renal stones that we are seeing. Maybe these patients may have a higher number of renal stones. So evaluation of asymptomatic hyperparathyroidism, what do we have to do? Targeting these complications, we usually carry out biochemically the bone profile, including PTH, and then bone mineral density using DEXA scan of 3 sites, hip, distal 1/3 of radius, and spine. Vertebral fractures can be assessed using an X-ray or a CT and trabecular bone score. Renal profile together with 24-hour urine calcium and creatinine, serum creatinine, stone risk profile, and renal stones nephrocalcinosis detection through X-ray, ultrasound scan, and preferably CT scan. What is the management of asymptomatic hyperparathyroidism? We know that symptomatic hyperparathyroidism, the treatment of choice is surgery, localization and surgery of the parathyroid gland. And what is in this asymptomatic group? Can we leave them alone? Because as I mentioned, there had been complications with renal and bone. Therefore, if a certain criteria for surgery is set and met, then we can go for parathyroidectomy. If not, well, monitoring is recommended. And criteria for surgery is calcium more than 1 milligram per deciliter above reference range. And skeletal parameters are DEXA score, T-score less than 2.5. I think I showed you the rationale of that decision. And vertebral fractures detected by CT-MRI or renal parameters, eGFR less than 60, having renal stones, or increased urine calcium excretion, and the age being less than 50. If any of these criteria are met, then with complications, then this can be taken as an indication for surgery. What about monitoring, the group that we monitor? The working group in 2014 had recommended calcium and PTH monitoring annually, skeletal monitoring 1 to 2 yearly with DEXA, and if it indicated to look for any fractures, renal calculation of eGFR annually, and if there are risks, to do stone profile and imaging. Now, I actually don't want you all to go through this. This is how it has progressed over the years, these criteria, 1990 to 2002, 2008, and 2013. I have highlighted the addition. So using 3-site DEXA measurements, and especially inclusion of vertebral fractures in 2013 criteria, and also inclusion of urinary calcium excretion and nephrolithiasis detected by not only ultrasound scan, CT. And again, monitoring criteria, they have increased certain parameters, especially like stone profile and renal imaging, including CT. Switching on to normocalcemic hyperparathyroidism, the definition, as the name implies, is persistently increased serum PTH level in the setting of normal albumin-corrected or ionized calcium levels after secondary causes of raised PTH had been excluded. There are several causes where you can get normal calcium and high PTH, like vitamin D deficiency, malabsorption, chronic kidney disease, medications, and idiopathic hypercalciuria. You need to exclude all these to call this as normocalcemic hyperparathyroidism. And mind you, it has to be persistent, at least 2 tests over 3 to 6 months. And prevalence-wise, this is a nice study just to show the importance of persistence. Osteoporotic fractures in men study, MROS study, has shown a low prevalence of 0.4% in this normocalcemic primary hyperparathyroidism group. Whereas DHS, that is Dallas Heart study, has initially at baseline shown a 3.1%. But over time, with follow-up, they have repeated this and found to have 0.6. So majority although had normocalcemic hyperparathyroidism, it had reverted back. Therefore, it is important to make sure that persistently increased serum parathyroid levels in the background of normal calcium levels are detected. And what is the pathogenesis? This group has normal calcium levels and raised PTH without any secondary cause. There are so many hypotheses, but unfortunately, we don't have very solid data to define any 1 or 2 mechanisms. But most commonest hypothesis that we see in literature is normocalcemic hyperparathyroidism represents an early or milder form of classic primary hyperparathyroidism. But aging, vitamin D deficiency, calcium sensing receptor abnormalities all are in the play, and more data is needed to come to a conclusion. What is the biochemical profile? This is a nice study in 2020 showing that the first one is about, I'm sorry you can't read, but I'll just mention calcium levels, second phosphorus, and the last one PTH. And this is no hyperparathyroidism, and this is our target group, normocalcemic hyperparathyroidism. You can't see any difference between the normal controls and this group with regard to calcium. But when it comes to phosphate levels, it is significantly different from the control group, as well as significantly slightly raised from the hyperparathyroid group. So it's in between. And obviously, PTH level is raised as in primary hyperparathyroid group. And when we check the BMDs, you may appreciate that from the control, there's no significant difference of distal 1/3 of the radius BMD in the normocalcemic hyperparathyroid group, whereas primary hyperparathyroidism, there's a significant difference of reduced BMD in the distal 1/3. So as a conclusion, the study group has concluded biochemical phenotype of normocalcemic hyperparathyroidism is intermediate between primary hyperparathyroidism and controls. In contrast, bone phenotype resembles controls with normal bone turnover, no significant BMD impairment, and no increased risk of vertebral fractures. So bone-wise, it's kind of more towards controls, the normal people. It's not behaving as primary hyperparathyroidism. Same group has retrospectively evaluated medical records of kidney stones, and normocalcemic hyperparathyroidism and primary hyperparathyroid patients had similar kind of percentages without any significant difference in presence of kidney stones, whereas controls had a lower percentage of kidney stones. But these are medical record analysis. It is not a planned kind of a analysis on renal stones. And there had been reports of non-classic association of normocalcemic hyperparathyroidism, like hypertension, aldosterone excess, cardiovascular mortality, hyperglycemia, quality of life. But we need more data to come to major conclusions on how these parameters are being affected by normocalcemic hyperparathyroidism. When coming to the management, the same study group of hyperparathyroidism working group in 2014 has proposed a plan that is to monitor DEXA, calcium and also PTH and renal profile, and if there is any progression to primary hyperparathyroidism, follow guidelines, and if progression of disease is noted, to go for surgery. Well, last few slides. If parathyroidectomy is considered, can we go ahead like in primary hyperparathyroidism? Well, caution should be taken. Why? Because they have noted that most of this normocalcemic hyperparathyroidism is associated with multi-gland disease and smaller parathyroid glands compared to other group, and higher persistence of hyperparathyroidism post-surgery. And lack of robust prospective data is a problem, and then case-to-case approach is suggested. In summary, asymptomatic hyperparathyroidism is common and is associated with bone and renal adverse outcome, and parathyroidectomy for individuals meeting criteria for surgery, and conservative management involves long-term monitoring. Whereas normocalcemic hyperparathyroidism, it is less common and it's a biochemical diagnosis. Data is scarce and pathophysiology is heterogeneous. Natural history is yet to be known, and surgical outcome data we are yet to see from a large series and RCTs. Thank you.